I was working at Muirhouse Medical Group, where I worked for from 1980 till 2022. And I'd been working there for a couple of years, and we'd been interested in the drug use problem that was emerging, and we'd been studying the problems that were emerging in Glasgow. Jason Ditton, who you probably don't remember, Jason was a sociologist in the University of Glasgow and reported on the rapid rise in heroin use in Glasgow in 1981. And then Sally Haw did that groundbreaking study for Skoda in 1983, I think, Dave, if I'm right. And then Dave came along with his study, looking at a prevalence study of injecting heroin users in Edinburgh. And that was a turning point. That was a turning point for us at Muirhouse. Here we'd been managing this caseload, well, quite a big caseload for one general practice in a locality of an epidemic, which we described as an epidemic of drug use. And we thought, well, this is a local problem, or maybe they've got some problems in Glasgow as well. But Dave came along with this study, and I remember very well the day we met, sitting in what we called our research room, which was just a little sort of attic space, and with Aidan Bucknell, who was a researcher we recruited with a small grant for the Scottish Home and Health Department. And we sat there and talked about this enormous number of people, young people, very young people. I mean, these were people, 17, 18, 19-year-olds, and in our area, many of them had been in sixth form at school the year before, and then they'd started using heroin. So we were aware of a huge problem. We were seeing cases of hepatitis B all the time, and our study, Aidan's study, was originally set up to study hepatitis B, little did we know that there was other viruses circulating at the same time in the same population. So things were, all of a sudden, Dave's information, we sat around and realized that big things were happening. We were witnessing something, a phenomenon that was new, and we didn't really know quite how to deal with it. And we were grasping around, desperately looking for advice, information. Working parties were not really terribly good. The clinical guidelines recommended 2-week supply of methadone, detox. That's it, problem solved, patient cured. The ACMD report, treatment and rehabilitation, was largely good stuff about, as Orlando says, Phoenix House, detox, rehabilitation over a period of sometimes weeks or even months, but nothing about acute cases of people coming in with injection sites and problems. So here we were in the middle of this, and just to put you in the picture, I guess this history slide is, I can remember all this happening. I can imagine most people in the room weren't around in 1970, but here we were with Mrs. Thatcher as a new Prime Minister and Ronnie Reagan becoming President of the United States, and all these other things happening. I still reflect that if Jimmy Carter had got into that election, the world would be a different place. And other things were happening. The Russians had invaded Afghanistan. The Olympics were banned, were boycotted, not by UK actually, and Scotland won a gold medal in the 100 metres. But that bottom in red, I think, is interesting. Moya Woodside at the Royal Edinburgh Hospital reported the first 100 cases of drug users in Scotland. The first 100 cases, and that was in 1973. And the second bullet point up from that, I think, is terribly important as well. I mean, this was the Scanlon report, and Lord Scanlon was asked by the government to report on inner-city riots in various places, in fact, many places in England. And he concluded that these were racially driven, and the focus was all on race relations and inequalities, but he also concluded, and I think that was relevant for us, that the state of the inner cities was bad. The state of the inner cities was decaying. Morale was low. And certainly we had, some copycat riots in Edinburgh and Glasgow, and it was all about poverty and inequality. It wasn't so much about race, but it did resonate, and that report did resonate. So here's the Drugs Policy Unit in 1979, and you can imagine that this is a tricky people to deal with. Not much in the way of sympathy or interest. And here is the house. This is, some of you will recognize West Granton in Edinburgh. And these houses were built by Erno Goldfinger's model. You know, he was into these high-rise landings and walkways, and there was some logic in it. And I personally don't think these would have been that bad if they'd been maintained, but they were neglected. They were in a terrible state. And by the time I was working there, you really did feel like you were going into a war zone, and half the place was empty, and there was dripping pipes, and there was dogs everywhere, and it was pretty wild. So it was not a good environment, and I think that was the backdrop to a lot of the problems at the time, and sadly resonates today, doesn't it? So what we were seeing was all these very young people with injection sites. I mean, this is all very familiar to you. Some of the older ones with femoral vein injection sites that have been going on for many years. I mean, this is a more recent slide, but you know, these were the things we were seeing in the surgery. And this was, I mean, this is a rather cruel slide, but this was, the businessman is saying here, if you can't read it, he's saying, granted it would save countless lives, but to what end? And it was all about money. It was all about money. That was government policy. It was all about the Westminster government were not interested in social problems and in deprivation and inequalities. So we without getting too political about it, we felt that, you know, we were up against sort of hostile forces in all parts. So moving on a little bit, this is about drugs policy, which is what I meant to talk about. Drugs policy was short-term detox. And we did send patients to Phoenix House, to South Shields. We did send people to Roma and London, which interestingly allowed injecting heroin. They supplied injectable heroin, and people were allowed to bring in their own heroin, injecting on site at that time. And we sent people to the lay community in Oxford. And then there was that, you know, rather ill-fated expedition in Cardross, Dave. Do you remember that? Willie Blaney and Alexandria, where this chap, Willie Blaney, a sort of entrepreneur, set up in the old Catholic seminary, set up a detox and a rehab unit, which was great. I mean, that was a great idea, but it all fell apart for various sort of funding issues, and I'm not quite sure what went on there, but it didn't work out. So that was what we were looking at. We were looking at sending people away and giving them 2 weeks methadone and think, well, that will cure them, you know, they'll be sorted. The psychiatrist in Edinburgh closed the methadone clinic in 1982, which wasn't very helpful. There were 1 or 2 GPs, interestingly, prescribing heroin. There was 2 GPs in Edinburgh who prescribed injectable heroin, along with the London-type model. But we weren't in a position to take over that because we had several hundred patients. And of course, Dave Little and Sally Hall's reports and the number of people using heroin came in to change things. Just, I mean, this is really for the medics amongst you. I mean, this is reminding, my wife says to me, well, you couldn't do anything in those days. I mean, medicine was pretty primitive, wasn't it? And I look back at the BNF, the British National Formulae for 1976, the year after I graduated, and that's it on the left there. And it's about 200 pages, and they renewed it every 4 years. Now the one on the right is like a telephone directory, and they renew it every 3 months. They update it every 3 months. So the change has been dramatic. I mean, we've lived through a time of extraordinary development, not just pharmaceuticals, but a lot is to do with developing new drugs. But that old formulary was full of lotions and potions and things you rub on and things you inhale and Friar's balsam and all sorts of weird stuff. So things were changing. And here, you won't be able to read this, but this is our case notes. This is our, the state of the case notes. And here's a patient's case notes with a sticker on the outside saying high risk of infection, danger of infection. And here, you won't be able to read this either, but I mean, I'll just read out a sentence out of this because I think it's really interesting. This is a letter from a GP to a consultant saying, can you please see this patient? And she's saying here, oh, I can't even read it from here. My patient has spent £600 in the past 3 weeks on drugs. My partner prescribed Fiseptone Linctus, 15 to 20 mils 4 times a day. He didn't return until 2 months later. He was back on heroin. I prescribed clonidine and Ativan. Clonidine is a drug you won't know, but it's a drug that was used for withdrawal symptoms. Ativan is a benzodiazepine. And he turned up again a couple of months later, saying he was on heroin again. He said he was still taking Ativan to help him sleep. So this is chaotic prescribing in a random sort of way, trying to treat symptoms and not really addressing the problem at all. And again, here's an extract from case notes in my own handwriting. And I find these interesting to look back on, because this is about the care of this young woman whose mother had come to me because she was using heroin. And the story goes on that she's off on. I'm giving her some benzodiazepines, a little bit of methadone, a little bit of this, thinking she's going to be cured. And then at the bottom of the page, it says, and by the way, we're going to do an HDLV3 test today because there's this new test that's just come out. So, you know, it's a piece of history. So we were struggling. We really were struggling at that time. I mean, there was a lot of stigma. Never goes away, does it? But I mean, there was local stigma as well. You know, people didn't want to come to our surgery because it was contaminated. There was a risk of violence, they thought, and they thought there was a risk of infection. And there was no doubt the staff were traumatized as well. Okay, so moving on quickly to 1985-86, George Bath and John Putherer published that letter in The Lancet, which reported some HDLV3 positive tests, some HIV positive tests in blood samples taken from the A&E department in Edinburgh Royal Infirmary. And then we published our report a year later, or 6 months later, showing that 51% of our caseload had this anti-HDLV3 HIV antibody in their system. I mean, it's important to remember at that time we didn't really understand the total impact of that. We thought, I remember speaking to Philip Wellesby, one of my consultant colleagues, and said, okay, Philip, what's going to happen to these people? You know, and he said, well, it'd be like hepatitis B. You know, most of them will get better, and probably a small percentage will go on to develop the full syndrome in a year or two's time, and they'll probably die, and that's it. Little did we know that actually there was an incubation period of untreated HIV was 10 or 12 years, so none of them would develop symptoms in the next few years, and all of them would die if they didn't get treatment, and there was no treatment at that time. So shortly after that, the McClelland Report, which Dave Little was a founder member of, or we only had a few meetings, didn't we, Dave? I mean, this is the best report ever. It was 16 pages. It was really short, of typed out stuff, and we made about 10 recommendations, and that was it. Committee dissolved, and it all took place in about 3 months. And that was the first committee, national committee anywhere that I think anywhere in the world that recommended that people give needles and syringes to people who inject drugs. So that was a real game changer, and it wasn't for another year or 18 months before ACMD in London for the UK did recommend the same thing. But as usual, Dave Little was at the head of it all. And the Home Affairs Committee came up, and we had meetings in some of the community groups. So this was really important. I mean, things were happening. I mean, New York, we knew New York had had an epidemic of HIV infection in drug users, and here was ours in 1983, which in fact, remember, we only got the test in 85, but the actual epidemic happened in 82, 83, before we knew it was there. We didn't know. And hepatitis C was circulating at the same time, of course. And then, of course, other epidemics took place elsewhere. We rather stupidly thought, well, you know, now that we've told the world about all this, nobody else will have epidemics of this. But I used to collect them year by year, and I gave up collecting them in 2009 until Glasgow in 2017, another little epidemic of HIV infection. So in many countries it's still going on, epidemics of HIV infection, and the numbers of drug users infected around the world is increasing all the time, I'm sure. Okay, so here we were with, in the middle of, you know, this epidemic of drug use. Everybody's pretty fazed by the whole thing, and nobody's got a good policy going on. We were all, in the practice, we were treating patients. I mean, we were seeing people like that caseload, you know, sometimes 2 or 3 times a week, and, you know, for various problems and prescribing trinket little bits and pieces of sedatives and tranquilizers and occasional Temgesic. We prescribed Temgesic, remember that? We were ahead of the curve on buprenorphine, prescribing Temgesic. And Dave reminded me recently that I was still at that time pretty anti-methadone. He reminded me, and you have a rosy view of your own history, don't you? And I had this vision of me being, totally a convert from the beginning. But that wasn't true. We were still, rather hostile to the idea that this was an ongoing treatment, that people should get treatment that, didn't have an end date or didn't have a quick end date. We were still in the short term. But then there was all this stuff. I mean, children with AIDS. I mean, gosh, people began to sit up. Even, I'm sure Mrs. Thatcher didn't, but even, the cabinet, Willie Whitelaw began to sit up. Norman Fowler, the people in the cabinet recognized there was something. This was a problem. It wasn't just a bunch of drug users. There was children involved. And these drug users were young people. They were young, they were heterosexual, they were having children. So, hey, there was going to be a risk of children getting infected with HIV. So all of a sudden, I wouldn't say the cavalry arrived, but a lot of interest became focused on it, and certainly the media arrived, and we had a regular queue of people outside the surgery door wanting to interview drug users, which we wouldn't ever do, but we were interviewed. So Norman Fowler did okay. Again, it's hard to describe the revelations that were coming on year by year. I mean, we were still thinking that there was a small number of people out there infected. The Paris conference in 1986, was it? 86, I think. 86, suddenly realized that actually there was this long incubation period for HIV. And therefore we had to look further back. There was people who were infected 10 years ago. And what about their partners and their partners and their partners? They were all infected too. So by the time the International AIDS Conference reported 100,000, possibly 100,000 people may have AIDS, there were several million already around the world, mainly in Africa, but there was probably 500,000 in the United States already infected with HIV infection. So, things were, you can imagine, the sort of year-by-year conferences, new revelations all the time. And there was money in it. There was all these rather bizarre sort of how many people get AIDS for Christmas. There was all sorts of bizarre sort of approaches to how you and then Glasgow, it was interesting, didn't have an HIV problem at the time. There were cases, but they were emerging slowly. What I've been talking about has been epidemics, where the numbers go up from 0 to, in our case, 50% in the space of a year or two. In most other places, Amsterdam, Paris, European cities, there was HIV, but it was creeping up gradually. And that was because the pattern of behavior was different. There wasn't the needle sharing that we'd had at the beginning there. Okay, so free needles could halt the epidemic. This was and here's a good picture, isn't it? It's not a very good reproduction, but here's Diana shaking hands with Jonathan Grimshaw. And this, again, its relevance today probably doesn't resonate so much, but that was a game changer. That really was. I mean, people suddenly realized that they didn't get infected by touching people or shaking hands. And Irving's thing, of course, was a great eye-opener for many people. I mean, it did us all a great service, I think, in dramatizing it, but in making people think and realize that these weren't terribly normal people, but there were normal people involved with drug use. And then there was the drug-related deaths report in 2000 from ACMD, which began this trail that we're still on. So just summarizing, there are other bad things happening still. I mean, this report of deaths, this WHO report, I mean, I think that was one of the most shocking reports I ever came across. The life expectancy of a man in Carlton district of Glasgow is 54 years in this report, compared to 82 in East Dunbartonshire. 30-year life expectancy difference. And if you take away drugs and alcohol, a lot of that goes away. So we have recurring themes in Scotland, unfortunately, and SDF at the bottom there, as leadership has been enduring throughout this, and I think that, when we've had all these sudden disasters happening, it's always been SDF that have turned up and analysed it and told us all and told government how to deal with it. So there, in all these episodes, Dave has been at the forefront. But an anthrax outbreak, that was extraordinary, and botulism, And the perfect storm described in the papers as the perfect storm of HIV in Glasgow in 2017 up to the present day. And our highest drug death rate in Europe, which hopefully is beginning to plateau. And there has been, of course, there's been obstruction to policy, and I think policy is moving, but it moves, for impatient people like me, it moves too slowly. I mean, I mean, this is just rather mischievous, really, but there's prescribing. I took this picture in Glasgow, Sackett, I'm sorry to say, a GP practice, which says, and it says at the bottom that this is in keeping with the Glasgow and Clyde, Greater Glasgow and Clyde Health Board prescribing policy. We do not prescribe these drugs. And there's a whole list of things, including methadone and temazepam and all sorts of things. You know, it's basically go away, isn't it? So, final slide, state of the sector. Well, this is around a history in one slide. 1960s and 1970s, what I describe as benign neglect. But there was concern about hepatitis B because we'd had that outbreak in the renal unit in Edinburgh Royal Infirmary where a doctor and a nurse had died, a technician had died. And there was concern about hepatitis B, but it wasn't, you know, our study was funded, but there wasn't huge concern in the 1960s and 70s. And then we had HIV, which I've talked about, the McClellan report, the introduction of antivirals, another huge turning point, 1985. The only international AIDS conference I went to ever was in Vancouver, and David Ho announced this antiviral drug that actually, you know, halted the progress of HIV infection. And that turned the tide completely, changed things completely. But since then, we've had multiple blood-borne virus outbreaks. We've had a policy, and I think we're moving towards an integrated policy. And I mean, I shouldn't be impatient because good things are happening. There is recovery and social integration. There's a wider spectrum of multimodal treatment services available and integrated care. And it's great to, you know, just talking in the introductory session through there in the coffee room, talking to people about how people are working together like never before. I mean, I think this is all, a lot of it's down to SDF.